I have nothing to disclose. The university pays, that's the only place it pays me. So this is just a basic outline, so we'll talk about this question. We'll attempt to answer this question, what is anesthesia? We'll go over different types of anesthesia, a set of specific goals that we try to obtain. We'll talk about general anesthesia, which I think when people think about anesthesia, that's usually what they're thinking of. And specific stages that we talk about, that you guys might hear us talk about at times, like stage 2, etc. And then sort of tacked on at the end is a brief history of anesthesia, just to give you sort of idea of what what has happened in the past to bring us where we are today. And so again, what is anesthesia is kind of a broad question, and so I thought I'd approach it Jeopardy style. And so if the answer is, what is anesthesia, this might be the question. So it's our specialty. We're focused on patient safety and perioperative care, whether that's care for a surgery or a procedure. And it includes things like pre-op evaluation, post-op care, like ICU care, critical care, pain medicine, acute pain treatment, chronic pain treatment, and then all these different specialties for intraoperative care, things like OB and peds, etc. So I would argue that that is anesthesia. But again, it's also a term that's used to mean general anesthesia. But that's not just anesthesia. It can also mean regional. You know, like we're going to give you anesthesia. And we might mean regional. We might mean a sedation, so like a MAC or a monitored anesthesia care, which, as you guys have seen, can look very different. The patient might be completely awake, the patient might be snoring. Anesthesia might mean a neuraxial block too, so a spinal or an epidural, or it can just mean local anesthesia. I'm sure you go to the dentist and the dentist says, well, I'm going to give you some anesthesia now. You know, in most cases, they're not going to give you general anesthesia, they're going to give you some local anesthesia to the site. So it depends what people are asking. But it can also mean just a general loss of sensation or a loss of sense or feeling, like if your arm falls asleep, sometimes people will refer to that as an anesthetic limb. It's a limb that has anesthesia. It's also a medical journal. When spelled in the funny British way, anesthesia is a medical journal. When combined with and analgesia, it's an American medical journal. And perhaps this is a stretch, but anesthesiology is also an American medical journal. It's also sung by Metallica. And I really wanted to talk about Metallica today, so I thought I'd include this. Thank you, Wikipedia. And I think you guys are probably all familiar that we are often referred to as anesthesia, as in, hey, anesthesia over here. Although perhaps then the answer is technically, who is anesthesia and not what is anesthesia. But I digress. Anyway, different types of anesthesia. Again, the gold standard, I think, what people are generally thinking about when they say it, it's general anesthesia, right? So that's when the patient's completely out, completely asleep, and we'll talk about that some more. But we also do regional, and regional can be the nerve blocks that we do out in the block bay. Regional can be a spinal or an epidural. And then again, there are the max sedations, so anywhere from someone being super lightly sedated, meaning they're completely awake, but we may give them a medication that makes them forget, to, you know, they can turn into general anesthesias at times where, you know, you poke them, you prep them, they don't respond at all. And then there's local, and local, when I say that, I mean, you know, regional is where you're specifically numbing a nerve. Local would be where you're not necessarily targeting a nerve, but you're targeting an area, like when the surgeon puts local anesthesia in the wound. And we will often combine these things, right? So we'll often do, for example, a spinal with a MAC, or a local with a MAC, or an epidural with a general anesthesia, right? Surgeons will often give local when a patient's under general anesthesia. So oftentimes we will combine these techniques. And then when we think about sort of goals or the tenets of I tend to think about these chronologically. So if you go out to the PACU and you meet your patient's very nervous. One of the things you want to do is provide anxiolysis or help get rid of their anxiety. And that oftentimes means you give them some midazolam or Versed. And I won't go into too much detail about medications because I believe you're going to have some pharmacology lectures in the future. But basically, Versed's really good at getting rid of anxiety. But it doesn't necessarily, our job isn't necessarily just giving drugs. We can provide anxiolysis by giving a little kid a teddy bear or having their parents there to comfort them, or we can be the folks there to comfort them. I mean, you guys are doing it all the time, right? When we do blocks and you're in the patient's position, you're reassuring them you are the anxiolytic. Question? A sort of at times dual goal is amnesia, so loss of memory. And again, midazolam is a good example of how we do that. So we say that midazolam provides anterograde amnesia, meaning after we give it, folks don't remember much after it's given, as opposed to retrograde amnesia, which would be, you lose things that have already happened. And so midazolam and perhaps propofol are really the only drugs, maybe scopolamine, that would do that. Of course, one of the really big things that we do on a day-to-day basis is provide analgesia, right? So preemptive treatment of pain, treatment of pain at the time, and then rescue treatment of pain, like when we do our blocks in the block day and people are in PACU and they've come out of their surgery but they're in such awful pain. And I think this is one of the coolest things that we do. We provide hypnosis. So we have this long list of drugs called hypnotics, which we'll talk about. And you see them every day. Propofol, etomidate, argaxes, what's the other one, ketamine. These drugs that cause people to become unconscious. And we call it sleep. You don't want to tell somebody, well, we're going to put you into a reversible coma today. It's going to be fine. So we tell people we're going to put you to sleep. But it's technically not sleep. It's just, people look at the EEGs, the brain waves are different. It's a reversible coma. But either way, you can think about it as a loss of consciousness or a hypnotic state. And oftentimes, we are trying to achieve that state during our anesthesia care. And it's definitely one of the big and most obvious parts of doing general anesthesia. And I'll talk more about that in a little bit. Another big goal is immobility. And so sometimes this means the patient's paralyzed, sometimes it doesn't. So a lot of patients, if you put them completely to sleep with the general anesthesia, they won't move. Many folks won't breathe, but sometimes you do need to truly paralyze them, which means you give them things like rocuronium, a paralytic drug. Spinals, like a dense spinal, I'm sure you guys have seen this on OB at times, that can cause immobility as well. And then another, or last, sort of less obvious goal of what we do is to decrease the stress response to pain. So if you can imagine if you or I experience pain, there's a fight or flight response, right? Our blood pressure goes up, our heart rate goes up, you feel nervous, you get a release of hormones and things like cortisol that can cause all kinds of bad outcomes. And so another goal of what we do in the OR is to try to prevent that. I'm sure you see us at times, we'll hear the heart rate increase, or we'll see the blood pressure increase, and we'll deepen their anesthetic, or we'll give them some pain medicine or whatever. Another goal is to try to keep those things at bay. Any questions about that?
So you're not trying to maintain all of these at the same time? These are all separate? They're not entirely clear cut. So
certain actions can achieve certain things. In a general anesthesia, I would say that we, the majority of the time, are trying to achieve all of these things, with the exception of sometimes we don't want to provide amnesia. Being unconscious will prevent you from processing what is going on, right? But we may not want people to forget what happened right beforehand. For example, I did a case the other day of a pregnant woman who had to have general anesthesia, and we did not want her to forget the birth of her baby. So we chose not to provide her amnesia at that time, although when she was asleep under general anesthesia, she would not have any memory of those, what happened while she was asleep. So that's a good question. We tend to achieve all of these things during general anesthesia. During other types of anesthesia, there may be one or two things that we're trying to achieve. If you can imagine if somebody is, awake and they're just getting like a local anesthetic and we're sedating them, they're not going to be asleep necessarily. And then we may be doing more non-pharmacological things to keep them from being anxious or keep them from moving, right? Because if we have an awake patient who's breathing on their own, we don't want to paralyze them, right? So it's clear, but it's not clear, is my answer. Any other questions? And then, again, I'll talk a lot about general anesthesia because we do it a lot, and it involves concepts that are hard to grasp at first. And so these are some terms that we'll use when we are working with the general anesthetic. You'll hear us think about induction. So like we're going to induce the patient. And all that means is we're going to start their general anesthesia. We're going to give them medications to bring their brain into that phase of general anesthesia. And that usually involves medications like propofol, etomidate, ketamine. With kids, we'll often do inhaled inductions, right? And it's still induction of general anesthesia. And then once they're asleep, we keep them asleep, and that's termed maintenance phase. And so we may do maintenance with the gas, like desflurane. We may do maintenance with propofol. We may do maintenance with a little bit of midazolam here, a little bit of fentanyl here, depending on the case. And then when we're done, emergence is when we stop their general anesthesia and we allow their brain to reawaken. And so these are terms that you'll, again, hear us use all the time. And then there are these different stages of anesthesia, general anesthesia specifically. And I think it's good to hear about these to better understand what you see when people are going to sleep and waking up. And as you can see, this is from 1937, so these are concepts that are very old. And they're concepts that are changing. This is another thing that these stages aren't entirely clear-cut. And these concepts, the field is sort of in flux right now about what they think about these concepts, and that's kind of above my head. But I still think that it's sort of a good, sort of easy benchmark to work upon. So I thought I'd mention it. You'll hear us talk about stage 2 all the time too. So anyway, as you can imagine, as we're putting the patient to sleep, they go from being conscious, and at some point they become unconscious, right? But there's that in-between period that would be stage 1. And that's when they're, not quite awake, they're kind of out of it, they may feel good, they may feel bad, they may talk about hearing things or seeing things, but their brain is starting to go to sleep. That would be stage 1. Stage 2, they're unconscious. Stage 2 can sometimes look kind of scary, it can be kind of confusing at times, because as their brain starts to go to sleep, there's this imbalance of inhibitory and excitatory input to their brain, and you'll see weird stuff, like you'll see them twitching, it might look like they're seizing, you might hear them phonate, they might go, and you're like, Emily, what are you doing? What's wrong with the patient? Well, I'm just going to sleep, it's okay. They might look like they're seizing. It can be really, really concerning if you don't know what's going on. And another big thing about stage 2 is that's when they're at highest risk of going to spasm. That's when they're at highest risk of laryngospasm. So laryngospasm is when their vocal cords slap shut and won't open. And as you can imagine, that's really bad because you can't get air through, so you can't oxygenate them. You can't get their exhalations out, so you can't get their CO2 out. So it's very dangerous. And so you'll hear us talk about, I'll talk about it in a little bit, but you'll hear us talk about laryngospasm in stage 2. Stage 3 would be like where we're aiming for. So a nice, stable anesthetic. And then there's this stage 4 that I've honestly never heard anyone talk about, which would be like overdoing it. You give them so much anesthesia that they're unstable, you know, their blood pressure's low. It's a bad thing. I've never seen it, but I suppose it's theoretically possible. And then you can imagine as they're going to sleep, they'll go stage 1, 2, 3. As they're waking up, they'll go stage 3, 2, 1. And so that's when, you know, as we're waking them up and they may be moving, and you guys are, you know, maybe not you guys, because you know, the surgeons are wondering, why don't you just take the damn tube out? If they're in stage 2 and we take the tube out, they're at really high risk of laryngospasm, which can be pretty serious. Again, if we can't break it. And so that's why we're looking at things like their eyes to see if their eyes are midline. You know, because if their eyes are all wonky, it means that their cortex isn't quite weak yet. You know, or if they're moving and they're not really making deliberate movements, that's another sign that they're not quite awake yet. So that's why, as they're waking up from general anesthesia, we're doing all these things to try to assess that they're truly awake before we take the tube out, regardless of how, you know, strong they seem. You know, and someone will probably talk to you guys about this at some point in the future. But the markers that one has to meet to be extubated, you know, strength is one of them, but consciousness is another one too, and they do not equal the same thing. So that's what we're talking about. Okay.
Can I put one?
Yeah.
That stage 2 is very noticeable in peds, and so that's one of those things that I've noticed we might have a little more relevance, is because it's hard to decipher the stage 2, stage 1 with peds. You'll have more frequency for laryngospasm.
Yes.
It tends to, depending on what anesthetic is used.
Yeah.
And then you see the erratic movements a lot more aggressively with kids, and you try to with mass induction and whatnot. So I don't know. Just as new people, they might see this a little more apparent here in peds land.
It's true. And I think it's, you know, at least for me, it's harder with kids at times because, you know, it's a kid. You know, you don't want to be mean to a kid, but and also as a new provider, you again don't understand what you see. But you know, our job is to keep them safe, and if they're thrashing about and such, they may be conscious and they don't like where they are, but they may also be in stage 2. And either way, we have to do what we can to keep them safe during that time. So that's an excellent example, and it's totally true that kids do it, go through sort of a harder stage 2. And young men too, like I'm sure you guys have seen at times when, you know, we'll have a big burly 20-year-old guy who got into some sort of trauma and we're about to wake him up, and you have everybody be really quiet, stay near the patient, hold them down just in case. Yeah, it's pretty interesting. Okay, so I'm going to end with kind of a quick review of anesthesia. And my point of this is that our field has come to be possible by several different advances. So the obvious ones, I think, are things like medications, right? As different medications become available, we have them at our disposal. But also monitoring has been a big thing because anesthesia used to be extremely dangerous. People would die because they didn't get enough oxygen. People would die because they got, you know, hypotensive or hypertensive, et cetera, or that they bled to death, et cetera. Anyway, so monitoring is big, and then different techniques that came along. As you can imagine, you know, we couldn't really give IV drugs until we had the ability to have IV access, and so the invention of the hypodermic needle is really important for anesthesia, along with other facets of medicine. Airway management is obviously a big thing as well, you know, being able to ventilate a patient, put the ET tube in, especially putting an ET tube in when it's hard. Like, there have been advances over you know, many years in that respect. And then in inventing all these different techniques, so inventing things like nerve blocks and spinals, etc. Those have all been big steps towards creating the level of care that we have now. So anyway, this is a picture from one of our textbooks of sort of the classic lack of anesthesia, where this guy's about to have a leg amputated, and he gets multiple people to hold him down while his leg gets cut off, and that's it. Sometimes these people would get alcohol as well, which alcohol is an awful anesthetic. It's not good for pain. If you get really, really hammered, you're apt to throw up or have other physiologic abnormalities, and throwing up is a bad thing when you're semi-conscious. What was the other thing I was going to say? That reminds me that NPO guidelines, so the invention of NPO guidelines, donate for this amount of time, was also a really big thing because we, improved or dramatically decreased the risk of aspiration of the anesthesia after that. But anyway, I'll move on. This will be really quick, and I don't intend to read all of this stuff, but throughout the ages, folks have identified different medications, natural medications that have anesthetic-like properties, again using the term anesthetic pretty loosely. Some of the earliest drugs were opium-based, which you can imagine. There was this soporific sponge that they used in the 9th to 13th century that included essentially morphine and scopolamine, so two drugs that we use now. So they sort of happened upon drugs that were helpful. In the 17th century, I think this was in Europe, this gentleman, Severino, found that if you put snow on an incision line and froze the skin, that it became anesthetic. Right? So anyway, I thought that was interesting. But he was also important at saving many lives during this diphtheria epidemic by putting in tracheostomies. And if you're not familiar, diphtheria is this bacterial infection where you get these really thick pseudomembranes in the throat, people can lose their airways. So, and this isn't like one of the first attempts at airway management. I think there's evidence back to the Egyptians that people would do trachs and such, but it was sort of an important point in history for anesthesia. And then there were these weird movements as modern anesthesia practice was starting to become what it is today. There were these weird movements like mesmerism, where people were essentially hypnosed during proper surgery. And people swore it worked and swore it worked. It does not work. And then we started to get the drugs that we use today. So one of the first inhaled agents was nitrous. And an important thing to point out was, again, before we had IVs, all of our anesthetic drugs were either eaten or applied topically or inhaled. And so some of the first proper anesthetics, like general anesthetic drugs, were inhaled. Nitrous being one of the first ones. And this is kind of interesting. So nitrous used to be a recreational drug. They discovered it, and there was a scientist who said, hey, I think this could be used for analgesia. It seems to treat pain. And nobody picked up on it, and instead it became this recreational drug for 50 years. And this dentist, Horace Wells, was at a party where people were using nitrous, and this gentleman who was intoxicated with it hurt himself. And Horace Wells, this dentist, noticed that the gentleman didn't have any pain. And so Horace, the dentist, decided to have another dentist friend pull one of his teeth while he was on nitrous. And lo and behold, it was painless. And so nitrous, first, a couple things there. First of all, it came about sort of by accident. And second, it became really popular in dentistry. But it's kind of hard to administer. Now we have all these fail-safes on our machines. People used to die because they didn't get enough oxygen with nitrous. Now we have all these fail-safes that prevent us from giving them a hypoxic mixture. But anyway, for multiple reasons, ether then really came to be more popular. And you guys have probably all heard about the ether dome and the first public demonstration of ether anesthesia back at Massachusetts General Hospital, which was in '46, where Morton gave this patient ether for removal of the neck mass, and really well. Another drug that became popular during about the same time was chloroform, and it was oftentimes used for OB analgesia, so women giving vaginal birth. In fact, Queen Victoria used it and liked it. Big endorsement apparently. And then in the 50s, a decade later, a century later, we start to get the drugs that we use today. So halothane being one of the first modern inhaled agents, which we don't use anymore because of side effects. And fluorine, again, side effects, we don't use it anymore. But now ISO, SIBO, and DES we use on a daily basis. So. And as you can see, sevoflurane and desflurane are actually pretty new meds, in context. Hypodermic needle came about in the 1860s. As you can imagine, aseptic technique was probably close to follow. Cocaine, as is today, is used a lot topically. They found it's obviously a abuse drug, but it's a local anesthetic too, like lidocaine, etc. And so people use it on the eye, people use it on the mucous membranes. And it was back in the 1880s when they really came to understand that it could be used that way. Spinals, believe it or not, were invented around the 1900s, like early 1900s. IV barbiturates about the same time, so things like thiopental. So one of the first IV induction agents. Brachial plexus blocks, epidural blocks, early 1900s. Paralytics in the 1940s, so we really didn't have what am I thinking of, medical grade paralytics until then. The pulse ox was huge, of course, to help prevent people from dying of hypoxia. End-tidal gas analyzers were huge too, so that we could monitor things like the depth of anesthesia with our gas agents and end-tidal CO2. And then 60s come around and we start to get our modern IV agents. And I think that's it, yeah. Anyway, it's been multiple advances in many different aspects, all in parallel to help bring us to where we are today. So sort of that's my point. It's very complicated. Any questions?
Yeah, what was the MPO acronym you mentioned earlier?
So MPO means nil per os, which I think is Latin, and it just means nothing by mouth. And so that's when, we'll ask all the time, is the patient MPO, etc. The strictest guideline is 8 hours, so we don't want anyone to eat or drink anything for 8 hours before surgery. There are some sort of nitpicky things about that that I won't go into, but having the stomach empty, which in most patients you can assume that if they haven't eaten anything for 8 hours or drank anything for 8 hours, that their stomach is empty, although we're sometimes wrong. That means when we make them unconscious if they throw up, they're less likely to have something in their stomach, and therefore less likely to have it go into their lungs. Because if you aspirate like that, it's really bad for you. A lot of folks end up, in the ICU, not for monitoring for, a ventilator. So, and back in the day, the 1800s, if that happened, as you can imagine, that was probably a death sentence.
Yeah.
So that was another big advance. Yes.
Could you explain what goes into a MAC a little bit too?
Sure. So it all depends. So I think technically, so MAC stands for monitored anesthesia care. So granted, during every case where they're going to monitor the patient, a MAC may literally be all you're doing is monitoring the patient. So you may not give them anything. They may get some local anesthesia from the surgeon. For example, some eye cases. I suspect there are some eye cases that we do where we actually don't give the patient anything IV. We give them oxygen and we monitor their vitals, and the surgeon does a block or the surgeon does a local. A MAC may mean you give some midazolam. It may mean you give some fentanyl. It may mean you give both. It may be like a colonoscopy or an EGD like we do over in GI where you run a propofol drip. And that's where you start to distinction between those things is how responsive is the patient. So, and that can be anywhere from they're awake, alert, and they're talking to you about what they did with their granddaughter yesterday, to, you know, you talk to them, they're sleeping, you talk to them, and they open their eyes and they respond. Or they're sleeping and you give them a sternal rub and then they open their eyes and respond to, you sternal rub them and nothing happens. You know, that would be more like a general anesthesia. So, MAC is, it's more challenging, I think, at times to explain than a general anesthesia. And oftentimes those cases are harder than providing a general anesthesia because there's that fine titration, which depends on the procedure and depends on the patient. And oftentimes you don't have a protected airway too. So you'll see us oftentimes having to, you know, support somebody's breathing if they have a MAC, for example. Good question. Any other questions?
When the patient's on emergence, what are you looking at, you know, on your monitors or the ventilator? You know, if they are kind of moving around but they're not quite awake, what are you gonna see happen with, I mean, is there gonna be much of a change or?
So are you talking about like their brain waking up?
Yeah, like how do you, I mean, but seeing it just on the monitors, I mean,
Sure.
outside of them opening their eyes and being a little more responsive.
So I'd say that, like the things that we look for to extubate a patient, like there's a list of things there that include, you don't want them to be paralyzed, you want them to be breathing on their own. You want them to be cardiovascularly stable, right? So if they're super hypotensive, you need to figure that out before you extubate them. But when it comes to regaining consciousness, we're mostly looking at the patient and less at the monitors. So we're looking for things like purposeful movements, which oftentimes means they're reaching to take out their LME or they're reaching to take out their breathing tube. Or they're, you know, well, trying to sit up isn't necessarily purposeful either because people may just be sort of reflexively moving. We're looking that their eyes are midline. We're looking that, you know, you say their name and they fixate on you, you know, that they're responding to you and they're localizing where you are. We're looking for those sort of more complex things. The distinction being we want to make sure that what we see them doing aren't just reflexes, that their cortex, like their, you know, the part of your brain that makes you awake and makes you, you know, an analytic thinker, that part is awake and that they're fully conscious. That's what we're looking for.
So to add to that, it's not that they're emerging and removing anesthesia, you're removing maybe portions because you are
Yeah.
still trying to localize the pain or
Exactly.
remove the local pain. So you're still delivering anesthesia,
Yeah.
it's just you're removing the general side of it and you see
That's
the
true.
emergence.
And that's where the, you know, our term just isn't very specific, and that's part of, you know, why I started this talk the way I did. Because it really just means what you mean by anesthesia. Like, they're emerging from general anesthesia, but odds are there are things that we've done that are still working. So like giving them pain medicine that's still working. Oftentimes these patients still have a decent amount of propofol in their system or anesthesia gases in their system. But they get enough out of their body that they're conscious, but you know they may not be really with it and awake, you know, and it may take 30 minutes, it may take hours for them to really be back to their normal selves, and that's a function of how long it takes those medications to go away, which depends on the patient. Yeah, that's a good point. And that's why, you know, it's the decisions that we make aren't always clear cut. You know, you may think, I just want to give this patient some midazolam, you know, because they're a little nervous. But you have to think, is that midazolam still going to be in their system when they wake up? And if the answer is yes, am I okay with that? Because there are some situations where we may not be okay with that, and that's a whole other lecture.
Right. And the use of reversals in this, because
Yeah.
those can take away your full anesthetic, like
Yeah.
Narcan, and
Yeah.
things like that. You could remove
Yeah.
all the pain portion of it.
That's a good point. So there are certain things that we do that have reversal agents. Opioids, we have Narcan. Benzos like gasoline, we have flumazenol, which we were going to use. The things like propofol, we don't have anything to reverse. You just, give them time. And our anesthesia gases, we don't have anything to reverse. You're just going to do it. And then some of our paralytics we can reverse as well. So we're also thinking about what we've given and what we believe will be the results. And again, that can be, that takes years of practice to have a gist of how a patient will react to what you've given them and whether they need reversal, et cetera. So, yeah, but when we're at the end of the case and we're reaching for naloxone, that would be why, because we think they're not waking up because of too much opioid. So, taking away that part of their anesthesia perhaps would give them a wake up.
Thank you.
Other questions?
Yeah, I have a question. So like the early anesthetics, you showed that picture of the guy drunk getting his leg amputated. So since amnesia is part of anesthesia, if he didn't remember that, if he got so drunk that he blacked out and didn't remember having his leg amputated, even though he felt it and went through all that pain,
Yeah.
is that a
Is that bad?
successful anesthetic? Is that bad?
So I think that's a valid question. In his example, I would say that, it was the best they could do at the time.
Right.
I would argue that compared to a modern anesthetic, it is bad because his body would still feel pain and he would still have those stress responses to pain, increased heart rate, increased blood pressure, et cetera, which puts you at risk for things like heart attacks, strokes. Nowadays, I think that there are times where we ask the same question to ourselves. So, for example, trauma patients who are so unstable that you can't really fully anesthetize them. For example, if they're bleeding, or usually the main one, they're bleeding, and so you really can't give them any gas to keep them asleep because it will make them have no blood pressure, which equals death. So there are cases like that where we will give them an IV medication to alter their perception of reality, with the hopes that if they live through that experience, they won't remember it, or if they do remember it, perhaps it will be less traumatizing. So I think that that's a valid question. Things are often not clear cut.
Just curious what your thought on that was.
Yeah. It's an ethics question, right?
Yeah.
And another thing, everything that we do on a daily basis is to take care of patients, right? Like that's why we're all here. But I think another facet to that is what the staff go through. As you can imagine, it must have been awful for these, people holding this guy down or the surgeon doing the surgery. Hopefully it was a very fast surgeon. But another facet of what we do is coping with seeing it ourselves, and that's something that you guys will experience. Being on OB when there's a patient whose spinal is starting to wear off, or seeing a trauma patient who is unstable and in pain and seems to be in agony, and you're like, Emily, why don't you just put the patient to sleep? Give him some gas. And I'm like, I'm sorry, I want to, I can't. Having to learning how to understand those stressful situations is important. Just so you as a provider don't feel like a bad person when you go home. There may be times on peds, for example, when you're holding down the screaming 2-year-old while we're putting in an IV. And it's in their best interest, I promise. Other questions?
Very good.
Don't you
Thank
want to
you.
go searching again?
Thank you, everybody. Enjoy your days.
Thank you, Emily.
Thank you, Emily.
Very good. You know, it's interesting, within the first year, I don't think I really knew what a math was.
Really?
Yeah.
And the other thing is, we talk about math all the time as a dosing of our drugs,
Yeah.
and that's a completely different term.
True. Yeah, I get you.
I don't remember what
They
it's
barely
called.
have a
I
half
don't
a math
understand how
club.
you're.
Yeah.
Exactly.
Right.
And that's a completely different concept.
It's just
Which, I used, funny, I went back